So that actually leads to some of the questions that are being submitted during the discussion by our audience. And a biomarker question is what came up first. What's the best biomarker for predicting sensitivity for a checkpoint inhibitor? What are you testing? What do you recommend we should tell people out in the community that should be tested? And even thinking one step forward, my question to you is what's coming, what's next beyond what is being tested now?
So, I mean, I think for me, it's a little easy, the first pass of that question, because there are only 2 approved biomarkers for these therapies, PD-L1 expression and MSI, and we don't really see MSI high much in lung. So, so that makes it easier. What I would say is that we do have fairly robust long-term survival data with PD-L1. It's probably the best single biomarker we have to date. I think the TMB we've already addressed is very intriguing. It clearly correlates with progression-free survival, but is going to have a whole host of challenges. There are a lot of very interesting scientific biomarkers, although some of them I find a little bit hard to sort of imagine. So there are things about where the T cells would be. But of course, we tend to have needle biopsies and sometimes even FNAs, which are going to make it extraordinarily difficult to make any assessment about that. The microbiome has been an area of much investigation, but are all of our patients going to be reaching into the toilet to find, to send something in? Maybe. And I think it depends on the strength of the data. So I think there's a tremendous amount of work in biomarkers. I think that it's interesting, and hopefully it will give us better biomarkers, and certainly it will give us a better scientific understanding.
And do you think it matters which PD-L1 assay you use?
We've generally used the Merck because it's the one associated with reimbursement, but I think there's, outside of the atezolizumab one that looks at the tumor cells and the infiltrating cells, there's more correlation, but I've generally just used the Merck out of simplicity.
And that's the 22C.
22C.
So a question for you, Tom. What are the options for treatment when a patient progresses after 8 months of osimertinib? And maybe I'll expand on that question. What happens if it was alectinib, or if they were ROS1 positive and on crizotinib? What are you recommending for your patients?
So I think the first step is I try and rebiopsy these patients, make sure there's not a small cell transformation or there's not a signal of what activation or mechanism of resistance is there. But assuming I don't find one that I can easily target, I think your options would be a platinum pemetrexed, or carboplatin, paclitaxel, bevacizumab, and atezolizumab. I've not used single-agent immunotherapy in this patient population, in large part due to Eddie's work on.
Not a group of patients that does well with the single-agent therapy.
No, it is not. It was. I guess if you prove your hypothesis disastrously wrong, you still proved something. So
absolutely, absolutely. So one of the other questions that came in is something we weren't really talking about before, but what's your experience with immunotherapy in small cell lung cancer? Maybe I can answer that one. Yes. So, we know right now nivolumab is approved in the 3rd line. There are not a lot of patients with small cell who get to 3rd line therapy. But we just had data from Empower 133 that compared carboplatin etoposide with or without atezolizumab, and that has been our first positive study in several years with small cell lung cancer. And so there was an improvement in overall survival, although response wasn't higher. It's hard to improve on a 60 to 70% response. But hopefully when approved, I think that is a regimen that I'm going to start using in 1st line for stage 4 disease. Any other data that you've seen that's exciting or out there?
So I think that's the game changer in small cell, because I think we've been stuck on platinum etoposide for 20, 30 years now, and I think it does show an improvement. I think we're all interested in the Nivo-Ipi combination, although it's an NCCN, but it's not approved. That obviously has a little bit more toxicity with the double immunotherapy. And I think the single-agent nivolumab has a response rate around 10, 12%, I think. And so it's modest activity, but those responses are durable. I hope this is just the beginning of immunotherapy. There are a number of trials, maintenance trials, and other combinations that are maturing right now. And hopefully we'll get those results in the next year.
Yeah, hopefully we'll see a lot more data at ASCO next year with these drugs. Anything different that you're doing or looking forward to seeing?
No, I'm just looking forward to having approval for the addition of atezolizumab because, again, this is a place where we really haven't had advances in a long time, and I think it'll be exciting to have something different to offer than what we've had, which has obviously been associated with a good response rate, but not great long-term outcomes.
Absolutely. Another question that came in, a newly diagnosed patient, are you seeing an increased use of NGS? And in cases where a single gene test must be done sequentially, what's your preferred priority that you're doing? Maybe you want to tackle that one, Eddie.
So the first one on the NGS, I don't know that I've seen lately a huge upswing right now, but I think the big question, again, is back to TMB, because you're going to need to get NGS and probably even at centralized laboratories if we're going to incorporate that into our standard practice. Again, I mentioned earlier, one issue is we don't like to keep going back into the block to get slides because it wastes tissue, which is of course very valuable for the patient's care. So we have been very reluctant to do anything that's going to be sequential testing. We want to get as much information as we can in one swoop.
And we know NCCN and other groups recognize sort of broader multiplex testing upfront, so you don't waste that time. Tom, development, we kind of touched on this before, durvalumab maintenance is not available. Do you substitute?
Personally, I don't substitute, nor would I use like a chemotherapy consolidation. I think we've been down that road before, and it didn't really benefit our patients, and it is associated with toxicity. So I think durvalumab is still the one and only standard of care.
So related to that chemotherapy consolidation, what do you do if a patient gets chemo-RT with weekly carbotaxol? Because a lot of people believe that you should be giving systemic doses of a platinum doublet. Where does durvalumab fit in, and what are you doing?
So I've struggled with this question too, and I historically gave the weekly chemo radiation, then the 2 cycles of carbotaxol with the understanding that there's limited benefit. But now I've been just doing the carbotaxol with radiation and quickly transitioning to durvalumab, trying to get within that 42-day window at this point.
You're doing a similar thing?
Correct.
I find a lot of the patients, if you can give cystotopicide, give it. Those who got carbotaxol are often not the patients who can even tolerate carbotaxol. That actually brings us to the top of the hour. Thank you both for an excellent discussion. We hope that you found the information to be valuable for your clinical practice, and thank you for watching OncLive News Network.